type 2 diabetes and obesity without saying. Liver disease, kidney disease, central nervous system, indications for migraines, the gallbladder, mental health, including schizophrenia and depression, COVID, long COVID, alcohol addiction, nicotine, opioids, cocaine, 13 different types of cancers, 30-ish indications that GLPs could be beneficial for all of these type of conditions.
The GLP-1s not only target like the addictive behavior by itself, they kind of break down that feed-forward cycle of addictive behavior.
I'll even go and say maybe the weight loss is a side effect. Maybe the primary outcome are all of these other 30 things that we're seeing. If you are on an SGLT2 and you're increasing insulin and reducing glucagon, that's the exact opposite of what you'd want for ketosis, but we're not seeing individuals creating less ketones on either of these two medications. I think the reason that we're seeing so many amazing success stories, when you put the medication together with the exercise and nutrition, these are the stories that are life-changing.
You are listening to Beyond Healthspan, a podcast that strives to decode longevity research to live better, longer, and without the guesswork. We do focus on more than just aging, as we'll explore some fascinating science shaping the future of human health, some advanced strategies, and breakthroughs that impact quality of life as well as your holistic well-being. So welcome back to the GLP-1 and Longevity Series. This is a special deep dive under our Beyond Healthspan umbrella. Brandon, Rich, and Jim here again, and together we're unpacking what might be one of the most disruptive health innovations of our time, how these GLP-1 medications intersect with longevity, with metabolic health, and the future of personalized medicine at this point. So each episode in this series, and this is part 4, so welcome back if you've hung around, we'll break down the science, the nuance, the controversy, and most importantly, what this means for your long-term health span. Today, we're looking at the pathways, the mechanisms, and research, and throwing everything but the kitchen sink into various use cases for GLP-1s at this point. So anything is on the table because a lot of this information is emerging at such a rapid pace in the GLP-1 context. Jim, without further ado, I know there are a whole galaxy and constellation of benefits that seem to be use cases for the GLP-1s that are just beyond this whole weight loss component of it. So maybe a good jumping off point from here would be if we can kind of bulletize, if that's a word, itemize what some of these use cases are, and then we'll kind of flip the hood back a little bit as we unravel our conversation today and talk a little bit more about what we're seeing with these various use cases.
Great. Thanks, Brandon. So I think Rich and Brandon would have loved for me to memorize this and not read it, but I am not that good as much as I probably have the ability to talk about all these. So here's the list of, I want to kind of frame this the right way. This is kind of the list of existing indications, case studies, anecdotal, some type of evidence that GLPs could be beneficial for all of these type of conditions. So, of course, type 2 diabetes and obesity without saying. And we've kind of covered cardiovascular disease, liver disease, kidney disease, central nervous system. We know that we now have indications for sleep apnea or obstructive sleep apnea, so it's indicated for that. But there does seem to be some indications for asthma as well. We're seeing some pretty good data around PCOS, again, a condition that's affecting a lot of our women or a lot of our female patients. We are hearing about the Ozempic babies. A lot of women are getting pregnant, or even couples are getting pregnant while on these medications. So it definitely seems to be some indication there beyond just the weight loss. On the bone health, we are seeing reduced cases of gout, osteoarthritis. We just had some indications on the new triple G that'll be coming out. I think we're going to cover, and Rich will be covering a little bit more, indications for migraines, the gallbladder, diabetes-related eye disease, possible connections to reduced pneumonia. Definitely seeing some great data coming out on immune system. And just to kind of take a breather right now before I give the final list, Novo Nordisk has announced that they have 104 trials going on just themselves. And these are very expensive trials. I think there's 104 trials going on because I think they're confident they're going to see indications. We're seeing things like increased physical activity, leading to better quality of life, connections between chronic stress syndrome, mental health, including schizophrenia and depression, COVID, long COVID, COVID indications, addictions. Novo Nordisk has got special GLPs that they're designing for alcohol addiction, nicotine, opioids, cocaine, Behavioral addictions, clearly food addictions are in there. So we have a whole medication class that are probably going to be dedicated to those. 13 different types of cancers that are related to, in many cases, obesity, psoriasis and eczema, gut microbiome indications. I think we're going to probably see some type of GLPs possibly for type 1s, which would be a blessing to kind of reduce the need for exogenous insulin. Thyroid connections. We're seeing a lot of data starting to come out and a lot of evidence around female menopause and how this could be beneficial for that population. Cataracts, fibromyalgia, epilepsy, ADHD. So 30-ish indications. We're obviously not going to be able to cover them all, but I would imagine that most of our listeners have some one of these, many of these, have family members. So definitely things that I think we're going to be excited to be watching as the indications come out in the coming weeks, months, and years. So send it back to you guys.
Jim, I would encourage you to take a sip of water because that was quite the extensive list, but that's a good thing because I think this is, everybody probably checks at least one of those boxes that could use some benefit and from the GLP-1 use. But Rich, to kind of, I guess, pull one and the first one, and just based on the mechanism of action of the GLP-1s in terms of the reward center and food noise and all that, maybe the good first one might be this addiction, this reward pathway, this impulse control type of thing. So let's start there.
I love starting there. I think it fits really well. Our previous episode really focused on the Alzheimer's, the dementia, and we were kind of living north of the shoulders and between the ears, focusing on brain health and GLP-1 benefits there. Makes sense that we'd pick right up, talk about addiction, some of that in this context. I know in previous episodes we did focus on because GLP-1s seem to have impacts across the entire body, and there's these systemic benefits, there's directed benefits with regard to specific organs, which we worked our way through on some of the more specific indications that were potentially had FDA approval, for example. The ones we're focusing on today are emerging, I guess, is how we could classify them. They are not that far along in the research, but it's really fascinating research. So our idea today is to kind of take a quick cruise through as many as we can, and we won't get through the whole list that Jim just shared with us, but some of the really cool things that seem to pop up for us at HealthSpan clinically more regularly. With that in mind, wanted to focus on for example, with addiction and the reward pathways. Obviously, food noise is something that is really important for people that are managing body weight or managing type 2 diabetes or just in longevity context in general to help make nutrition a little bit easier, just because that can be a challenge for so many people. Is really important. So there are GLP-1 receptors built into your brain, into the reward circuitry there, as we kind of discussed in our previous episode. And there's some dampening of dopamine-driven compulsive behaviors. So certainly the trials that are ongoing, as Jim mentioned, will be super cool to see in terms of interesting things or kind of this roundabout research that I somehow found that I thought was fascinating with regard to addictive behavior or substance addiction and that type of thing. I found a study called the Chief Cohort Study, about 3,000 participants from the Taiwanese military, and they looked at different, for example, different behaviors that they had, whether it was active alcohol consumption, smoking. They highlighted betel nuts or areca nuts, which kind of are analogous I guess in a USA context to chewing tobacco in some capacity, except for their nuts. And they have a little bit different chemical, I guess, signature and how they affect the body. Nonetheless, they're stimulants. So there's some similarities there, and they do contribute to cancer risk, and there's things like that. So what they found was that metabolic health and addictive behavior or use of substances like this are intrinsically connected. Reason I might be bringing up, why does this matter? This is crazy. Rich is off on one of his tangents again. Is because GLP-1s have this dual capacity that's very unique, I guess, in my opinion. With this particular study, they found that metabolic disease, metabolic syndrome, and addictive behaviors were linked in such a way that it's 78% higher incidence of metabolic syndrome if you have at least one or multiple of these addictive behaviors, whether it's alcohol, smoking, or in this case, areca nuts. In that case, the GLP-1s not only target the addictive behavior by itself, they kind of break down that feed-forward cycle of addictive behavior, feeds metabolic syndrome. They also address, obviously, as we talked about in episode 1 with regard to type 2 diabetes, the metabolic ramifications of this. So GLP-1s are very fascinating in a number of ways, but that was just, kind of one off the off the wall, maybe, so to speak, study that I found that was like an interesting dynamic between metabolic syndrome, addictive behaviors, and one opportunity GLP-1s have to address that.
And Rich, I'll just tack on one little thing. I think we kind of touched on it, and I don't know whether we were perfectly clear, but GLPs have limited ability to cross the blood-brain barrier. But I think what's important is they hit signals that are able to cross. So it doesn't have to be a first order derivative to get the benefits downstream.
That's a great point. Yeah, I know we talked about like specific exantide or liraglutide or specific ones they've measured. There's even like some nasal delivery, which maybe that's part of what the Novo Nordisk and some of the trials that they're going on, different specific deliveries to enhance getting past the blood brain barrier and then having that direct effect. But yeah, fascinating that way too, that you can actually have second order molecules or signals go across the BBB, which we might trip over less, and then have effects that way in the brain with regard to addiction.
So succinctly, there's just less kind of impulsive decision making at that point as a result, way downstream of taking the GLP-1s, right?
I believe so. And actually, Jim, you were educating Brandon and myself about anhedonia. This I don't know if they would be directly implicated here, but I wonder if there's a tie-in here.
Yeah, no, that's great. I think that is good timing. So anhedonia is just less joy from something that should be joyful. We are seeing it with this medication a bit, but mostly on the higher doses. Maybe you enjoy exercising a little less. We've seen people say, "Oh, I enjoy shopping less. I enjoy some social interactions less." I think Oprah just a couple days ago mentioned that she enjoys alcohol less. But it does seem to be at the higher doses. One of the things that I think is interesting, and I kind of learned this from Spencer Nadolsky, if you don't follow him, Spencer and Dr. Lift is a fantastic program. One of the things that I learned from him and I'm doing with some of our members is anybody experiencing this, backing off the dose a little bit, especially if you're at the higher dose of a Zepbound at 15, taking people down to 12 and a half to 10. He's experiencing, I'm seeing some early evidence that people are starting to lose more weight again because maybe some of that anhedonia, some of that activity level actually picked up in a good way. So I think it's a great tie-in, Rich. I think it's a great point that this philosophy that you start and go to the highest dose and that's the way to lose the most weight. I don't think that that's the right path. And even if you did, the difference between the higher doses of Zepbound and the highest dose is very small. The benefits mostly from the lower doses. So I think when you put those two things together, I think if you are an individual that's struggling a little bit or maybe hit a plateau at the higher doses, I think, work with whoever's your provider to maybe come down a dose or two, and you might be surprised to see that you get that benefit.
Minimum effective dose.
One of my favorite sayings ever. Yes. And everything we do.
All right. I love that. So I guess ultimately, yeah, then GLP-1s may at that point restore choice where there might have been some kind of drive or compulsion that once at one point dominated. So I think we kind of tie a bow on that. Cool. I think that wraps up the addiction part of it, reward center part of it, and then jumping ahead into the headaches, the migraine sort of field at this point. Rich, what do you think the exact mechanism there with the GLP-1 use might be beneficial for this type of population?
I think, yeah. So with regard to the exact mechanism, might be jury's still out or the research is still yet to be definitive in that case. But there's several mechanisms under investigation and several likely contributors in with regard to how GLP-1 specifically target chronic headaches or migraines. And there's some interesting, diversity in the research, I guess, in terms of the results that I was looking at as well. But nonetheless, with regard to like how they, what pathways and how they would influence specifically migraines or headaches. Obviously, there's glucose regulation. There would be inflammation reduction that we'll probably get into as well with regard to some other indications that we'll be focusing on here. And there's some central nervous system tie-ins, as we were just talking about with the addiction. And obviously, the previous episode, we were focused specifically on the central nervous system with regard to cognitive decline, dementia, and Alzheimer's. But these drugs do seem to have, there's some evidence that they reduce neuroinflammation. and they may influence vascular function, which we brought up as well. So often there's a combination there, and it's not always the same. And certain people who struggle with migraines, often that struggle can be something that lasts months, years, and certain triggers are hard to identify. And it's a very difficult thing to struggle through. So there's been some mixed data, it seems, with regard to like some trials, for example, they suggest that GLP-1s, there's like a side effect associated that is, whether it's calorie deficit, fasting, or dehydration effects. There may be some mild headaches that are attributed potentially to GLP-1s. But when you look at like the systematic review of the data, it seems like there's specific GLP-1s in particular. The one that popped up, which I know, Jim, you may have some notes on as well, and maybe just like as we're watching this data progress and we don't have all the data for all of the versions of the GLP-1 receptor agonists that are available, but liraglutide has this analgesic effect that can help with pain tolerance, or it can reduce sensitivity to pain in animal models, but also reduce inflammation and pain reception, or, perceived pain with regard to GLP-1 use, people who have chronic headaches. So in terms of like the actual mechanisms, I think there may be plenty or several that are underway or being investigated currently, but there is this interesting, kind of multi-pronged, where it's likely going to be related to some level of fueling, maybe related to glucose, inflammation, and then even there's some evidence that there might be intracranial hypertension or blood pressure, the actual blood pressure within the brain or the blood vessels that feed or surround the brain tissue, that might have a role as well, which is pretty cool. I find it comes up frequently enough that I'm always interested when I see new research coming out on chronic headaches, migraines. Often that's just such a mystery box, so to speak, where it's hard to help coach people or work with them because there's so many, and a FODMAP diet or like something extensive like that is kind of hard to navigate all the time. So if GLP-1s have this extra added benefit on that side of things, that would be amazing.
Yeah, and Rich, I think it's a great point too that we are seeing a lot of the studies indicating benefits before the weight loss. And I know I've made this point in other podcasts. The weight loss matters for all of these things, but there's clearly other signaling going on. There's, like you said, vascular dynamics certainly in play here. We're seeing this through like blood pressure data where we're indicating that people's blood pressure is going down before you would expect it with the associated weight loss. So multi-path, I think we're going to be learning about these for decades to come. And I think they're also going to, I'll go as far as saying this time next year, we'll probably have 5 more medications to pick from. And in 3 or 5 years, we're going to have 20. So I think there'll be all different variations when I go through that list of 30-ish possible ways in which you could treat. I think you're going to have medications that are targeting specific outcomes.
All right. Well, I think that exits us from migraine stuff, headache stuff, and I think maybe the next appropriate topic is more in the orthopedic, athletic performance, potentially bodybuilding category. And I think I can kick us off there in that, when you look at specifically somebody like in the orthopedic category that have OA, knee osteoarthritis, something like that, each pound of body weight lost reduces about 4 pounds of load reduction on the knee joint with every step. 1 pound lost, 4 pounds less stress pounding on that knee. And that's both the vertical force and then sort of the torque, the moment arm that goes with the knee bend at every step. So that's just walking. That's not even running or trying to do anything else. And so when we consider where this 4x number comes from, 1 pound lost, 4 pounds of torque or force less on the knee joint, losing 1 kilogram of body weight, which is about 2.2 pounds, reduced that knee compressive and resultant forces by about 4 times per step. So simply put, 1 pound loss, 4 pound less per step on the knee. Small reduction, I guess, again, in that knee abduction moment arm that happens there, but that's less twisting, that's less bending, especially on the medial component of the knee joint, if you think about that, which is certainly going to be beneficial for your cartilage as we age. If we think about that practically, let's just say we lost 10 pounds. So your knees experience roughly 40 pounds less load with every step that you take. And if you extrapolate that over the course of a day, that could be thousands of pounds of load that's removed over that whole course of the day of just walking. Again, that's not running, that's not trying to do anything else. But I think if you were to make the analogy from everyday life, I have sort of 2 things that come to my mind. from an anecdotal experience. So if you were rucking and wearing a whole vest of weight and things like that, you're trucking along and doing what you're doing, and then take that thing off and you feel like you're walking on clouds after that point. That's one way to consider what your knees might be experiencing with that 10 pounds of weight loss. If you have ever gone ice skating, if you've gone up to Rockefeller Plaza or something like that, and Christmas time up in New York City, when you take those ice skates off and then put your sneakers back on, it's like, like things just feel better, and that's the joints just saying, thank you. And it's such a better feeling that I don't think people are aware of until they actually truly feel it. I know there's a testosterone component that comes along with all of this, Jim, and not to go off the rails with trying to pull pieces of the puzzle back together and how far reaching the constellation of benefits that come along with this. But I think you have 150 points in terms of T produced after something like that weight loss?
Yeah, yeah, and I think that that's a great point. You made several, Brandon, that we have seen actual evidence and even in clinic that individuals that lose something in that neighborhood of 5 to 10% of their body weight, testosterone pops up by 100, 150 points, which is, thinking about, you're not going to get that from any boosters. You're going to need a medication to get anything close to that. So that's why I think it's important to, when you are trying to treat, we treat people with, hormone replacement therapy, but if there's a card to play before going on testosterone, especially if you're still in an age where you may be considering having another child, I think that that's a consideration. And before going some of these other routes, this is a good big rock to move. And then Brandon, also one of the things that you had me thinking about, I don't even, I told you guys, but there's actually research that when you lose the weight, putting the vest back on for short periods of time does seem to trick the brain into thinking you're still that heavier individual. And you kind of look at, some of the research out there about how maybe metabolism slows or ultimately, your set point factors in. There does seem to be some growing evidence that putting the vest back on is tricking the brain. So to not think that that extra weight is having all kinds of consequences in every system is overly simplifying the way the body works. So you made me think about that research. And I know you look at like different things that we've seen about set point and tricking set point and being thoughtful around how you titrate off the medication if you choose to. There's definitely some cards that are yet to be played.
Cool. So that was I guess more of the orthopedic standpoint, and I know probably more specifically for somebody with something like knee osteoarthritis. If we take it a step further for somebody that might be in more of the athletic field or bodybuilding field, Rich, have there been use cases where people have deployed the GLP-1 for their specific, I guess, health goals?
Yes. Seems like there's accumulating, I'll call it early and or partially subjective evidence, mostly survey-based type stuff. And I have a new vocab word that I'll bring up in a moment. But first, I want to commend Jim on working in the set point thing. That may be even worth like an episode at some point, just because that's such an interesting topic within the research field. It seems like clinically it comes up often, but I don't see a lot of research on it, to be honest. I've seen some studies with regard to like what this set point hypothesis is, that your body like has this kind of semi-permanent, body weight and or calorie need that it like wants to hit. And that's what like in some cases kind of like the rubber band effect of like losing weight and then snapping back, and like you're trying to like reverse or adjust this set point, which GLP-1s more than likely, really are a mega pair of scissors to help cut the rubber band, so to speak, in some cases, so that you don't snap back and then have like, if your set point has been kind of semi-permanently established at a weight that you would like to adjust or change. Nonetheless, back to your primary question, Brandon. There has been some interesting studies. I guess there was one, I guess since we've flipped to 2026, October 2025, there was a study, mostly survey-based data again, where they were asking exercisers, recreational athletes, familiar with GLP-1 agonist drugs, if they had contemplated using them, or if they had used them to improve physical appearance or sport performance. And kind of like we're getting into this like not clinical realm anymore. We're more so in this optimizer realm, which aligns, I think, a lot of times with people, in the health span community, in many cases focused on longevity and already may be healthy, but they just want to maintain that health as long as possible. So there's this prophylactic or preventative mindset. And they found that like well over a quarter of the people that they looked at had either tried or were contemplating or already like kind of in process leveraging GLP-1s to help them, usually again at the lower dose range. The only other thing that I guess with regard to athletes and trying to kind of dive into some of that research, an interesting paper that I found was a netnography study or a netnography publication where focused on, I don't know if you're familiar with netnography. It was a new word for me. If you're not, basically, this is a type of research where they look at online study of cultures and community. Usually it's based again on like some kind of verbatim interview. And you're going to like ask people, it's not quite a survey. You're kind of actually talking to folks. But they did that in previous bodybuilders who were asked about GLP-1s and what that did to either the longevity of their love for a sport or a career within bodybuilding and how they've been managing it on the longevity side of things. It was a fascinating study. It was really interesting that these GLP-1s are increasingly being looked at for these longevity benefits. The bodybuilders in particular say that they're after them to reduce inflammation, enhance, feelings of youthfulness. There's all these quotes around how they're tackling age-related diseases, but also they're able to manage polypharmacy. If you've been around bodybuilding, or I guess if you're familiar with Ronnie Coleman, you can see kind of like the toll that bodybuilding at the highest level took on his body potentially. There's a lot going on there, but either way, there's inflammation, there's joint pain, there's different things that you kind of sacrifice in the long term for the immediate gain of muscle mass and strength and that type of thing. So it was really cool. The verbatims in there talks about like different dosages that work, and often it's again this minimum effective dose range that Jim is usually recommending on the longevity side. So it was really cool case in point. And although it's anecdotal, I found it very fascinating. Just wanted to share.
Well, I don't know why they didn't include me in the bodybuilding case study at that point.
Schmanden,
Yeah,
I definitely have qualified.
Exactly. Rich, some great points. I mean, if you kind of look at some of the stuff the bodybuilders done, good and bad, I guess I've been fighting with a number of people over the last few years about the muscle loss associated with the GLPs. I would love for somebody to show me the evidence and the pathophysiology of how there's more associated muscle loss with this medication. If that was true, why are all the bodybuilders, including people like Mike Israetel, who's pretty well regarded in the community in terms of his success and also his knowledge in the field. I think ultimately, kind of what Brandon indicated, keeping the doses low, and I don't advocate for micro doses, even though we don't have a set definition of microdose, but minimum effective dose, staying in the lowest dose, going slow and low, I think makes all the sense in the world. But I think from a overall health standpoint, if you become leaner, ultimately dropping weight and having a disproportionate of weight, say 75% of that being fat and 25% of muscle, I think it's hard to argue that you're not going to be metabolically more sound at those lower weights.
Yeah, that's a very good point, actually. um, if yeah, maybe not every bodybuilder is convinced that they need to maximize and grow lean mass outside of being in competition, or like after these were kind of previous bodybuilding athletes. But I'm sure that they're aware of lean mass loss. And my guess is, like you had kind of pointed out, Jim, they're unlikely to participate in this type of publication and be interviewed and do this type of research if, for example, GLP-1s were contributing in some kind of significant material way to loss of lean mass. It probably would not be. At least the verbatims in there were like primarily glowing positive reviews, how they like, these GLP-1s are checking all these boxes with regard to like when I go to the annual physician visit, but also like my knees feel good. I'm back in the gym, able to do things I wasn't able to do previous. Like those types of benefits are adequately hard to measure in research. So I guess like the verbatims kind of get us a first glimpse of that. And I'm sure Jim, as you're working with folks so consistently and diligently over the years, I'm sure you're seeing that all the time, and you've been talking to us and mentioning that all the time, that these things are not causing like dramatic lean mass losses that are contributing to increased risk of frailty right away, like all these things that people kind of might have concerns about, especially in the longevity space because of the value of muscle and lean mass.
Well, if you consider any kind of weight loss, it's typically going to be visceral fat, right? And so there's less of the cytokine flooding that's going on there. So when you reduce TNF alpha or interleukin 6, things like that, and that's allowing you to get back in the gym the next day and crush it again all over again, I think that's probably, at least in this population, the benefits that they're experiencing from the use of GLP-1, I would imagine.
Yeah, and I think it's every level. If you're 200 pounds overweight, and I've worked with several people that have lost, well over 100, 150 pounds, you get atopic fat, kind of the fat where it doesn't belong. So you're getting that, and you're seeing like improvement, like liver conditions. Obviously, the heart's pumping better. Then you get into the visceral fat, the fat around the organs, like Brandon was referring to, and then the elites are trying to get rid of kind of the subcutaneous fat. So every population is improving. It's almost like saying if somebody has level 3 obesity, moving into level 2 is a huge win. If you're in level 2, moving into level 1, if you're overweight, I get frustrated sometimes where people talk about cosmetic weight loss. If you are a 150-pound woman and you are 15 pounds overweight, however you want to define that, that's 10%. We have multiple studies showing metabolically how much 10% weight loss contributes to health. So is 15 pounds of weight loss per 150-pound woman cosmetic? I say no way. I mean, we've got tremendous data showing just the opposite. At 5%, you are metabolically better off. At 10, whole nother group of conditions improved. At 15%, you are metabolically not even the same person anymore. So when we talk about cosmetic weight loss, yes, if you're trying to drop 8 pounds to get into, your college suit, that's very different than, what we're seeing from the lion's share and the biggest portion of this population.
Well, I put on my college suit every day before I go to bed. Make sure it's still the good. Cool. Yeah, in terms of exercise, I don't know if there was anything else that popped up for you, Brandon. There was, at least for me, like the topic of complementary yet independent effects of GLP-1s was one that I saw within the research, where you have, biomarker improvements, BMI, waist circumference, which kind of goes in line with what Jim was mentioning, but like the hand grip strength and muscle strength on the lower extremity, respiratory performance or cardiorespiratory performance with regard to like potentially like a walk test or something like that, or even like a VO2 max test. I know we've kind of brushed up into that a couple, maybe an episode or two ago, but I do think there's this hand-in-hand benefit with GLP-1s where there's this, the results that you get or the benefits that you get are on the exercise side for longevity or just generally. The reason that maybe some athletes are looking to GLP-1s is because of a lot of these complementary yet independent benefits that they kind of stack well on or click together well, where you want to maximize the combination, but also you're missing out if you're only doing one. Like if you're only doing the exercise lifestyle stuff and trying to optimize as much as you possibly can there, then sometimes adding a GLP-1 seems like a no-brainer in that case, just to make sure that if you're putting that much effort investment on maximizing your performance, then there's opportunity to be had there with like this low dose GLP-1 exposure. You might even limit the side effects actually too, which we've talked about. The minimum effective dose limits side effects. So I don't know if exercise does anything to enable lower doses. That's an interesting question that's come up, I guess, for me, where like in the exercise oncology realm, for example, you find that like you can either tolerate higher doses of treatment for cancer and therefore the treatment is more effective, or you can get away with lower doses and have like, because the complementary benefits of the exercise. Like, I don't know if that works with and maybe there's no research yet to date on that, but that is something I wonder about. If, as we talked about, like modulating your dose, we were talking more on the addiction side, but maybe there's some of that too. If you layer on a little bit of exercise or do, some of that complementary stacking, you may be able to modulate the two, or do a little less exercise and, vice versa.
Yeah, Rich, it's oversimplification, but I think about it as a three-legged stool. The medication's one leg, the nutrition is another leg, and then the exercise or activity is that third leg. And again, there's other parts of that may be subgroups, but I think that that's a good way of thinking about it. But you're right. I think if you are just going to do the meds, you're only going to have so much benefit. Just like if you just exercise, you're only going to get so much benefit. If you just do nutrition, I think the reason that we're seeing so many amazing success stories is that the people that are committing to it and are working with professionals, and I think Brandon had found some research about how much more successful people are on this medication when they work with a trained professional. When you put the medication together with the exercise and nutrition, these are these stories that are life changing.
Yeah, monotherapy can get you so far, but I think when you add these other layers, it's what you should be doing anyway. It's a no-brainer. All right, so moving right along, I don't know, we hammered neurodegeneration to some extent with the Alzheimer's and dementia in one of our previous episodes, but to kind of pull in, potentially Parkinson's, multiple sclerosis, things like that, which neurodegeneration is a probably hallmark of each one of those conditions. I know, at least personally speaking, I was actually supposed to do my thesis in multiple sclerosis and exogenous ketone supplementation to try to prevent some of the demyelination. Some of the animal models show at this point with multiple sclerosis at this point that there's some remyelination, which is one of the hallmarks of multiple sclerosis deterioration at this point with the GLP-1 use. Jim, I don't know what your thoughts are. I came at it with the approach of beta hydroxybutyrate and exogenous ketone supplementation. Like I said, unfortunately, COVID hit and I didn't get to do the study, so I got nothing to say about it. It was just purely mechanistic at that point, unfortunately. I still think there's something there, but it seems like the remyelination component of what the GLP-1s hit, at least for the MS population, might be pretty provocative.
Yeah, I was watching a podcast. I think it was out like a week ago. So if you look back, Eric Burdan, who's at the Buck Institute, and I can't remember. I'm really embarrassed. I don't remember the other individual's name because he's pretty well regarded in the field. But he just talked about, and what they kept talking about is ultimately chronic inflammation, what that means for all the neurosystems, everything at a systems organization standpoint or system standpoint. I think ultimately we're going to find that it's not going to be one thing. Just like I think when we ultimately get some success around Alzheimer's and dementia, it won't be one thing. But I think when you're bringing down the inflammation across the systems level, then you start getting into the Parkinson's and the dementias and the Alzheimer's and the multiple sclerosis. And I think ultimately that is going to be, I think we're going to get more targeted medications that'll be GLPs. Remember, we have a triple G coming out. There's going to be fours. There's going to be combinations. I mean, I kind of think about it as trying to solve a Rubik's Cube with a blindfold on it. Like, unless you've ever solved it beforehand, and we do see these kids solving it, but you could have never done that without seeing it in the first place. I think we are now seeing the Rubik's Cube, and there's going to be so many different iterations of that. And that's why, I'm very excited about what this means for bending the curve for longevity and health span.
All in, I guess we can tie in 1C at this point, fibromyalgia at this point, Rich. And, it's a chronic pain sort of syndrome too that rears its ugly head every once in a while. And so I don't know if there's implications for the GLP-1 in that population either.
Yeah, it seems like based on again, we've moved the minimum criteria here in some capacity. There was a abstract that was published in 2025 in the Annals of Rheumatic Disease. Either way, the fibromyalgia part was quite interesting because it's related to like chronic pain, characterized by fatigue, and it usually has a significant quality of life impact. So with this abstract, again, this is not a full published paper at this point, as far as I can tell. I was only able to find the abstract thus far, but hopefully it's in progress or in press or on the way. They did find, when they looked at the study was interesting. It was a large TriNetX database study. So they had two cohorts, ended up being over 38,000 patients in each one, looking at those that were using GLP-1s and those that were not. So cohort A was GLP-1, cohort B had no GLP-1. The results were fascinating. Again, this is more of like a cross-sectional design. It's not interventional in this case, and there's probably medications and things beyond what was going on with the GLP-1. But those people that were on GLP-1 had a number of positive results, and this was assessed over a 5-year follow-up period. They had lower risk because they were less opioid exposure, less, because the GLP-1 pain interface in terms of reducing some of the pain that they were experiencing. Therefore, they were less opioids, so there's significantly lower risk in cohort A with the GLP-1s. Similarly, reduced reliance on care and kind of seeking help at the healthcare system or at your local care team, according to the research. The prevalence of malaise or fatigue associated with fibromyalgia in cohort A was less, and then also specifically like pain and rating scales of chronic pain and unspecified pain were much less, or significantly or statistically significantly less in cohort A. So there's a bit of a hypothesis, therefore, that would indicate that you actually have a reduced symptom burden associated with fibromyalgia patients as a result of GLP-1s being involved in what they're doing. It may not be the reason that they're having that, but it's doing something to amplify the effect of what they're currently doing, whether or not they're using more traditional treatment plans and things. But adding that on seems to have a significant impact. I find it very important. I know we talked about addiction in some capacity, but either way, like with regard to opioid dependency and kind of managing pain associated with this condition, fatigue and quality of life, I think that it's really cool research. So I'll be on the lookout for more of that as well.
I think I would be remiss if we didn't bring in SGLT2 to this topic of conversation. So I know we throw out a lot of letters and numbers, and it seems like we're making things up. So we have the GLP-1 and the SGLT2 to intentionally oversimplify the mechanism of action of the SGLT2. If you think of your kidneys as sort of this waste management system, they're tasked with reabsorbing things back into the blood system or essentially excreting or peeing it out. And so when you take the inhibitor, you make that decision-making process for the kidneys to some extent. So you end up peeing out 350 so calories extra of glucose per day. Major benefit for somebody who might have prediabetes, type 2 diabetes, because less glucose back in the blood system, less insulin response, A1C comes down. We see some metabolic flexibility. Jim, don't hate me. Improvements in renal markers, so creatinine, BUN, EGFR. We see lipid protection at that point. And like I said, metabolic health tends to improve. And so if you kind of put that alongside the use of a GLP-1, which is weight loss in its own regard, I'm wondering if these two have any redundancy or if they've been looked at together where one is better than the other, one's worse than the other. When you pair them together, is that double the effect? I don't know if studies have looked at that yet, Jim. I know there's various GLP-1s at this point, so I don't know. It might be too nascent to kind of place a verdict in that, but I don't know if you were aware of any of those studies.
Yeah. So one of the things, and I have a bias here, so I'm gonna preface it with that where before I start. But anybody who's in longevity space, if you're not don't know who Brian Kennedy is, you should know who Brian Kennedy is. He came out of the MIT Garanti lab with David Sinclair and Matt Kaberlein. So you're talking about the top minds in the field all seem to be coming out of a very prestigious. But Brian makes the point that you may know something and have confidence in A, B, and C, whether it's a medication or a supplement. But when we do this, we don't know. And A, B, and C is as likely to equal -1 as it is to equal +3 or above. What we do know is that the GLPs and the SGLT2 don't have that dynamic. We have real studies that show that they are both beneficial, different pathways, work very well together. So that is, less concerning to me when I think about that. I don't, I think we all know how polypharmacy has got a bad reputation, rightly and wrongly so. And that, we have things like some individuals taking 20, 30, 80 supplements. I don't know how you could possibly know what they're doing. I'd also worry about all the fillers on those. So to answer your question, Brandon, yeah, GLPs and SGLT2 seem to be born to go together. Different pathways work very synergistically. And also, if you are dealing with prediabetes or diabetes, neither are what they call diabetes medications of concerns. Neither are associated with low glycemic conditions. So I think that that's another positive, that if you put them together, you're not increasing your risk of having a low blood sugar.
That's a good call out. I think we get that question more often than I put stock into, where, if I'm taking these things that are going to ultimately lower my blood sugar, should I be concerned about these hypoglycemic events? And we don't, at least from the patients that I work with, and I'm sure that you work with, probably zero hypoglycemic events or concerns in that regard. So
Absolutely. Yeah. And I think also even glycemic excursion, it seems to, like Brennan indicated, about, anywhere from 50 to 90 grams of glucose are getting peed out. But if you had, not that it's physically possible, if you had zero carbs, the body would create some carbs. But even in those situations, we're just not seeing individuals low. The body seems to know to create more glucose. And the SGLT2 says, hey, I don't need to do anything here. So you're not peeing out what doesn't exist. So I think the SGLT2 and GLPs, I hate to call them smart medications, but they seem to know when they are needed and when they're not.
Yeah, that's the coolest part, I guess, from my perspective with regard to both of those. It's the way, and it's been a routine question. I guess I ask it less. I feel pretty confident now. But the question that I always had gotten is, well, these GLP-1s, they drive up insulin. And then if they were to kind of do that just as a baseline, just driving insulin up, that will contribute to insulin resistance. But because of the way that they respond to elevations in glucose and nutrient signaling in the body, that's like what you were saying, Jim, smart medication. And then similarly, the way the SGLT2 inhibitors seem to work, seems to be, modulated by how much carbohydrate, how much glucose you have in your bloodstream. And if you have more in your bloodstream, there will be less that's reabsorbed because it is, blocked at that inhibitor site. And then if you have less that's in your bloodstream in terms of your glucose concentration, you're going to pee out less. And it kind of, maybe it's smart is the wrong word, but it kind of functions like like he had said, a smart medication. It's really cool.
Yeah, and even for the keto and carnivore individuals, we have a lot of people that do that, practice that. We're not seeing situations, even with keto or carnivore, where people are getting low. Even things like diabetes ketoacidosis, very little evidence that the SGLT2s even causes that in a keto environment. So I think that's a real strong testament. And even to Rich's point, if you think about it, if you were on an SGLT2 and you're increasing insulin and reducing glucagon, that's the exact opposite of what you'd want for ketosis, but we're not seeing individuals creating less ketones on either of these two medications. Just shows how intelligent and how how the body seems to know how to adjust when dosed properly.
Yeah, I hope Daniel doesn't kill me for this one, but he's our CEO, and when we were trialing this SGLT2 medication, I think he had a very stressful morning and took down a bunch of Snickers, and he was like, I was peeing every 20 minutes. And so it's just, there's certainly a context to it where it depends on your sort of foundational approach to nutrition in terms of what's going to ultimately be the, urinary output at this point. In this case, Snickers being more of a refined processed carbohydrate, he was peeing a little bit more. So
yeah, Brandon, Daniel's on the other line. He said he needed to speak to you after the call. After we finish recording, he said just to give him a quick ring.
I'll see you guys later. It's been fun.
What happens on Halloween stays at Halloween.
All right. I think I have one final topic that I think are relevant for the GLP-1s here, and it's a little bit outside of my wheelhouse, so I'm ready to learn a little bit, Rich, about more of skin conditions. So in the context of psoriasis and eczema, what the implications and applications are for the GLP-1s for that type of population or use case.
Yeah, it's we can probably go fairly quickly through it. It's definitely an area that I find fascinating. I have children, and I would say like 50% of them, depending on what they're eating, seem to have various eczema reactions. But also people that I'm working with consistently are, challenged by certain, skin conditions, general, but sometimes psoriasis related or eczema. So there was some from, late last year, 2025, there was some evidence that was published where it does suggest that there may be some GLP-1 effects in terms of mitigating psoriasis in particular in this study, but perhaps other skin conditions as well, because of how there's these, it's just something we've brought up time and again about GLP-1s. There's these systemic effects that are not just related to gastric emptying being slower, and they're not just related to managing glucose levels. Because of managing glucose levels or insulin levels, there's indirect things that might happen, but in general, there's a lot of other benefits associated with these that we're still, as we've discussed, we're still kind of learning about. So that was one that kind of piqued my interest when I was going through all the, the various 20 to 30 indicated conditions or indications for GLP-1s that Jim had kind of listed out for us at the beginning of our episode here. Outside of just the weight loss and glycemic control, which is very cool, it's compelling research, but sometimes, it's not as new, it's not as interesting, because in some cases it's a little bit, there's just more volume of data there, so we're a little bit more convinced, and sometimes the controversy or the new stuff is a little bit more exciting. So what they did find, basically, that because there's some regulation associated with even on the immune side of things, right? So within a psoriasis context, there's natural killer cells and some AMPK activation within the psoriatic plaques, and AMPK is a nutrient sensing part of the metabolism profile. It actually sometimes can be impacted by a variety of things, not just GLP-1s. In fact, rapamycin, if I'm not mistaken, has some effects there, and obviously changes in nutrition would in that case as well. But there are benefits associated with people who have coexisting metabolic conditions as a result, where they have shifts in immune function, natural killer cells that might be upregulated or kind of out of range a little bit, and then AMPK as well, that might be a little bit hyperactive in this case. Through the metabolic benefits that come with GLP-1s, there's these plentiful spillover effects. So no surprise that in this case, if you can use GLP-1s and maybe you're kind of seeing some benefits on the metabolic health side. Often what they're finding is there's these kind of extra or complementary benefits that might happen with regard to skin conditions that you may have been dealing with that you didn't take the GLP-1 originally for, but that's coming up in some of the research, and enough so that they're actually doing dedicated studies on it now. So yeah, anytime you improve your metabolic health or potentially become more metabolically flexible, you're avoiding future energy crises, and avoiding energy crisis is critical to any kind of longevity or any kind of condition that there's, things are systemically so connected inside the complicated biology of a human that I think that is the reason that times like SGLT2 inhibitors, GLP-1s, they have so many really cool indications that they're showing some positive benefits with, because they're anchored, I think, in that metabolic health context.
Rich,
Yeah,
why
and
did
Rich,
you
I think
tell Jim earmuffs
yeah,
before you said metabolic flexibility?
yeah, exactly. And Rich, if I remember that study, I think that what was fascinating to me, just like the heart study, was those benefits were showing up well before the weight loss and well before you probably would have ever thought. So again, pathways we don't yet understand are clearly being triggered.
Yeah, and I mean, you can improve metabolic function, on a shorter time scale than you would improve, obviously, like weight change. Weight change takes longer than metabolic adaptations might. Maybe long term, it takes some time to get your baseline to shift and have your metabolic health shift in that way. But like a couple hours or maybe 12 hours of not eating, right? You scientifically are defined as being in a fasted state. That's a very different metabolic scenario. Even sleeping is classified as a different metabolic state than being awake, in terms of how your body fuels, etc. So yeah, I think it makes sense to me. Although it's very important to reiterate, as you had said, Jim, because I think a lot of times the GLP-1s are just, they're weight loss medications, and people just kind of like brush them off and then kind of forget about them. And that's maybe part of the reason we're doing this series. There's so many really cool ways that they connect or intersect with longevity that it's worth tracking. It's worth spending some time chatting about.
Yeah, and I'll even go and say maybe the weight loss is a side effect, right? And maybe the primary outcome are all of these other 30 things that we're seeing in the weight loss. I have a couple patients I'm working on with right now. They have no intention or desire to lose weight. So we're managing the side effect, which is the weight loss. Have a program to be able to get these other downstream benefits without losing weight. So it's completely possible, especially, if you get the dosing right.
That's really cool to kind of think of it that way, because not everybody wants to lose weight, but
Yep.
there's a lot of people that fit the category that still want a lot of these other benefits, or at least some of these other things to be impacted, which we barely scratched the surface, I suppose, on like that giant list that you shared.
Like
Yeah,
I
and
said,
again,
since
I don't want.
yeah.
Sorry, Ben. I was gonna say, I don't want to take away from the importance of the weight loss, but if this
Mhm.
class of medication didn't cause weight loss, I still would call it a generational medication. Sorry, Brandon, I didn't mean to cut you off.
No, you're good. I think that sort of set the stage then for what you alluded to in the beginning, Jim, is that there's a whole heck of a lot of trials ongoing currently with a whole heck of a lot of money being spent on those. And so which ones I think tickle your fancy the most? And then if you can sort of tie that into what's coming next, which is the Wegovy oral, and what we should be excited about for anything that's coming in the future to kind of round this out today.
Yep. So I'm very excited about PCOS because a lot of the women I work with are experiencing that. I do think we're going to get some more readouts on the neuro. So I think we'll get dementia and Alzheimer's readings. I know the last trial was a little disappointing, but I think there was some issues around that. And Eric Verdun from the Buck Institution talks about that in his podcast as well, that that study wasn't necessarily designed. It was later stage. The dosing probably could have been higher. So I'm not going to ever let one study get me overly excited or overly disappointed, because I think the most of the evidence we have before that. So that's the one I'm most excited about. But I think we're just going to be surprised. We're just going to look up, and every couple weeks we're just like, wow, another indication. Like, anybody that use the CPAP, man, they're life changing, but they're not fun, right? So the obstructive sleep apnea, getting off of that has been life changing for a number of people I work with. So that's it again, the indication. I think the liver, heart, and kidney stuff that we've covered. In terms of something I just wanted to cover real quickly because it's top of a lot of people's minds. The Wegovy tablet or pill is now out. They have 4 different doses. Novo Nordisk did give us indications of how, if you were on the shot, how to transition. So I'm glad they did that because I was trying to do that myself. So they gave us some good indications on that. What I think is important to know about this medication, you have to take a very specific way. You have to take it fasted, and you have to take it with less than 4 ounces of water. Yes, 4 ounces. And then you can't do anything for half an hour. When I say anything, you can obviously move and exercise and take your shower. But you can't take any other medications. You can't drink anything more. You can't obviously eat. So that is a little bit of a restriction for some people that have to start their days in certain ways. But they have 4 doses. The outcomes are very similar in terms of weight loss. Still indicated for heart. They haven't come out with the MASH indication yet. I don't know why they held that up, but it does seem to be most of the benefits, and hopefully all the benefits that have been indicated for the shot will apply to the pill. But just want everybody to understand, if you do the pill or the tablet, you want to be very mindful. If you do not do it the way it's intended, you get 0 benefit. If you are not going to wait that half an hour, you're going to chug a big glass of water with it, just might as well throw your money away. It's a lot less expensive. It's still significant money. So again, you need to take it on an empty stomach. Could you get up at 4 in the morning if you were fasted for 8 hours and take it and go back to sleep? I don't think that would be a problem. But a lot of people that are doing thyroid medications, you would definitely have to wait on that because you need to do that fasted. So if you're on a thyroid medication, you wait the half an hour, then you take your thyroid medication, then you're supposed to wait another half an hour for that. You can kind of see how the days can get a little tricky. But no, I think it's going to be a fantastic medication. It's from Novo Nordisk. It's the same as their Wegovy shot. And then we are expecting probably in the coming weeks, maybe a couple months, Eli Lilly's version will come out. A little less weight loss, but the advantage of the Lilly tablet or pill is that you can take it anytime. Doesn't need to be fasted. Don't have to do some of the restrictions. So I think they're going to both have, significant markets for those that don't want to poke themselves. I will tell you, a lot of people that I talk to are saying, man, a little shot once a week is just easier than remembering every day to take, a tablet or to have that restriction around when they can start their day.
And now, Jim, that was with 4 ounces of what again?
Water.
Oh, come on. I thought you said water. I thought we were on the same
So
page.
water. We had that whole discussion about water and water. Yes, that's water. Yeah. So another one of our little inside jokes, but yes, 4 ounces or less. Less seems to be more.
H2O.
Yeah, H2O. And believe it or not, a half an hour is like the minimum you need to wait. There does seem to be some additional benefit of waiting longer. So some little nuances are starting to come out.
Is there an upper limit? I can already see people. I took my dose and then I waited 12 hours.
No, actually, that would be beneficial. Yeah, I mean, no, I think a marginal return, but great point. I think there's a marginal return with time, but it's all about the stomach acid inhibiting the ability to get into the lining.
Gotcha. Cool. Well, that's cool that that's out. And I'm sure some people will be jumping right on to that. And that's exciting too.
Oh, got multiple queued up, ready to go. I think a lot of people are waiting. I think a lot of people do have the a little bit of the fear of the needle or just don't want to. It's a different commitment when you're taking a shot if you haven't before. Also, I think that the dosing schedule is very slow, which I like. There's 4 doses, and I think that that's going to be allow people to get to minimal effective dose.
All right. Well, the next few weeks/months should be pretty exciting, and hopefully we just continue to learn about the constellation of benefits that these GLP-1s seem to reach and seem to help people. So we're pumped, and we're here for that, and here to be part of the support team that works alongside you guys. So reach out to us anytime. With that said, I think this wraps up this chapter 4 of our GLP-1 and Longevity series. So hopefully this conversation today and the previous 3 gave you some clarity, challenged you a little bit, sparked some curiosity. So share it, subscribe, leave a comment, let us know if we missed anything, and we're happy to follow up and answer any other questions. Certainly this is a lightning fast evolving field at this point. And so we're here hopefully to help you stay ahead of the curve with some of the nuance, with some science, and what hopefully is overtly expressed as a lot of compassion about this, because we deeply care so much about this, and we're here to support you guys. So we'll see you next time for the next step in understanding some of the future of longevity medicine, and thank you guys for tuning in.